Imagine having a headache so severe and so constant that it just completely steals years of your life.
Yeah, that is a nightmare scenario.
Right. And then, to make it worse, imagine finally getting in front of a doctor only to be told that you might just be making it up.
Oh, the medical gaslighting. It's incredibly frustrating.
It really is. If you're listening and you've navigated chronic pain, or if you've spent, hours in a neurologist's waiting room getting conflicting advice, you know exactly how exhausting it is.
Absolutely. The standard approach is almost always just a new chemical pill.
Exactly. But today, our mission for this deep dive is to explore something that totally flips that paradigm. We're looking at a stack of medical excerpts and patient stories from Dr. Lowenstein. He uses a highly specific, sometimes controversial, mechanical solution to chronic headaches.
Which is nerve decompression surgery.
Yeah, nerve decompression surgery is fascinating. So, to give you some context on the sources today, we've got a really unique mix here.
We really do. The sources combine these highly granular surgical techniques like what actually happens to the nerves and bone in your forehead with these intense first-hand patient narratives.
It's a wild contrast.
It is, but it gives us this complete picture of the journey, from chronic suffering all the way through to surgical recovery.
Okay, let's unpack this, because to understand how this surgery changes lives, we really have to change how we think about headaches. We're moving from the abstract concept of just pain to the literal physical geography of your head.
Right, the mechanical pinching of nerves.
Yeah, it's like fixing a house's wiring or a kinked garden hose. If a wire is pinched tightly inside a wall, you don't just pour chemicals on the wall, right?
No, obviously not. You'd open the wall and give the wire some room.
Exactly, give it room. So let's talk about the back of the head first, the posterior surgery.
So the major player in the back of the head is the greater occipital nerve, or the GON.
The GON, right.
Yeah. This major nerve travels up from the spine, weaving right through the neck muscles to give sensation to the back of the scalp. And in some patients, that muscle acts like a literal vice grip.
So what does the surgeon actually do?
Well, they actually remove a column of that muscle around the nerve. They dissect it down until they can drop the nerve into a soft, fatty layer where there's no pressure.
Wait, hold on. If you are carving out muscle and actually cutting around there, doesn't the patient lose the ability to move their neck or, feel their head? That sounds like a fast track to becoming a bobblehead.
I know, it sounds extreme, but no. The actual volume of muscle fibers they remove is, it's microscopic compared to the sheer mass of your neck muscles.
Oh, okay.
Yeah, clinical data shows patients experience absolutely zero deficits in neck strength or motion. The nuance, though, is in how they handle the different nerves.
What do you mean?
Well, they decompress that major GON because it covers a huge sensory area, but they also run into smaller satellite nerves. The third occipital nerve, the TON, and the lesser occipital nerve, the LN.
And what happens to those?
If those smaller ones are inflamed or trapped, the surgeon doesn't decompress them, they actually just cut them.
Wait, really? They just sever a cranial nerve on purpose?
They do. Because those nerves only provide feeling to tiny localized patches of skin, the sensory loss is barely noticeable. But they don't just snip it and leave it. They bury the cleanly cut nerve end deep into healthy muscle.
Why bury it?
To prevent pain. If a nerve is cut and left alone, it tries to heal by sending out these chemical signals searching for a connection. If it can't find one, it forms a painful scar ball called a neuroma. Burying it in muscle basically suffocates those signals.
Wow, that's incredibly clever. So that's the back of the head.
Yeah.
But the anterior surgery, the front of the head, is totally different. I found it so fascinating that they actually use cosmetic eyelid surgery incisions for this.
Oh yeah, blepharoplasty incisions.
Right. They hide the scars right in the natural crease of the eyelid or up in the hairline. You'd never even know they had brain-adjacent surgery.
It's brilliant plastic surgery technique applied to neurology. So in the front, you have the supraorbital nerve, the SON.
The one that goes through the eyebrow area.
Exactly. And it has to turn a sharp corner through a totally rigid bone tunnel in your eye socket. For chronic headache patients, that tunnel is just way too tight.
So they have to break the bone.
Yeah, they use this specialized tool called a wronger. It's basically a bone-biting tool. They use it to open the roof of that tight bone tunnel.
Ouch.
I mean, you're asleep, but yeah, it's microdemolition. And they also remove fibers from the corrugator muscle. That's the muscle that furrows your brow.
Ah, okay. So it's both bone and muscle trapping the nerves in the front.
Yeah. And just like the back of the head, they also divide and bury some smaller nerves in the temples, like the zygomaticotemporal nerve, or ZTN, and the auriculotemporal nerve, the ATN.
Okay, so the mechanical fix is obviously super straightforward.
Yeah.
Find the trap, remove the trap, or bury the smaller nerves.
Yep.
But here's where it gets really interesting. If this is so effective, why isn't it the very first thing every doctor recommends? We have neurologists and pain doctors actively warning patients that you should never, ever cut a nerve.
Yeah, the controversy here is massive.
I mean, to play devil's advocate for a second, if the literal brain and nerve experts are warning against this, shouldn't you listen to them?
Well, if we connect this to the bigger picture, it all comes down to selection bias.
Selection bias. How so?
Think about the environment where a neurologist usually encounters a severed nerve.
In a hospital?
Right, but specifically in trauma, they see nerves that have been severed by uncontrolled trauma. We're talking car crashes, severe kitchen accidents, shattered glass.
Oh, I see. So the nerve is jagged and mangled.
Exactly. It's ripped apart in a non-sterile environment, and it's left to heal on its own. That uncontrolled healing is what leads to those neuromas, that painful nerve scarring we talked about earlier.
So a neurologist's entire clinical experience tells them that a cut nerve equals devastating, intractable pain.
Yes. But they're comparing a chaotic car crash to a highly controlled, sterile surgical environment. It's apples and oranges.
Because in the surgery, the cut is clean, and it's intentionally buried in well-vascularized tissue.
Precisely. Neuroma formation in this specific surgery is exceedingly rare. But the neurologists just don't see those successfully treated patients.
Because the successful patients are out living their lives. They aren't going back to the neurologist.
Exactly. The neurologist's perspective is completely skewed. They give well-meaning advice, but it's based on inaccurate, trauma-biased data.
That makes so much sense. Okay, so having addressed the safety and that whole medical controversy, I think the natural next question for someone considering this is, well, what happened after?
The recovery phase.
Yeah, what is the actual aftermath of letting someone operate on the nerves in your head? The sources break the recovery down into 3 distinct buckets: activity, aesthetic, and pain.
Let's start with activity because it's pretty strict.
Yeah, the sources mention you need caregivers for the first week, right?
You do. Basic daily tasks, what we call ADLs, are fine within a few days. You can brush your teeth, walk around the house. But you have 1 full month of absolutely no strenuous activity.
Because you have to protect those deep tissues.
Exactly. If you elevate your heart rate, you get swelling and blood pressure spikes in the surgical bed. That can ruin the meticulous decompression work.
Okay, so that's the physical activity. Then there's the aesthetic recovery. For the back of the head, they use staples in the hairline.
Which sounds scary, but it actually allows the hair to grow right through the scar, hiding it perfectly.
Right, but the face is a bit different. There's this highly specific and honestly slightly humorous surgical rule of thumb mentioned in the texts.
Oh, 2 weeks for your friends, 3 weeks for your enemies.
Yes, I love that. So what does that actually mean for the patient?
It's all about the eyelid bruising and swelling from those blepharoplasty incisions. After 2 weeks, the bruising is fading. Your friends won't care. They know you had surgery.
Right, they'll just be happy to see you.
But if you have to go back to a professional setting, or see people you don't want to share your medical history with, your enemies, you need a full 3 weeks for that delicate eye tissue to look completely normal again.
That is such a pragmatic way to measure recovery. Okay, so the third bucket is pain. And this one seems wildly unpredictable.
It really is. It's the hardest part for patients to wrap their heads around.
Because some patients wake up in the recovery room and they are instantly cured. Just boom, pain, gone. But others experience this aggressive waxing and waning pain for up to 6 months.
Yeah, the central nervous system has to recalibrate.
Right, because the nerves have been sending pain signals for years.
Decades sometimes. So even when the physical pinch is gone, the brain is still trapped in a chronic pain loop. It takes months for those nerves to settle down and stop throwing biochemical tantrums, basically.
Biochemical tantrums, that's a great way to put it. So what does this all mean in terms of actual success? What does the data say?
Well, medically, a success is defined as a 50% reduction in pain.
Which, for chronic migraines, is huge.
It is, but Dr. Lowenstein's recent review of 95 patients showed a 91.5% success rate.
Wait, 91.5%?
Yes, and even better, nearly half of them, 48.4%, were completely 100% pain-free.
Wow. That is staggering for a condition that usually resists all medication. But what about the ones who aren't successful? The texts mention revisions are possible.
They are rare, but possible. Revisions usually happen if a nerve was previously damaged by something called radiofrequency ablation, or RFA.
That's where they burn the nerves to stop the pain, right?
Exactly. RFA causes internal scarring in the nerve, so just making room around it during decompression might not fix the internal damage. In those cases, the surgeon might have to go back in and actually divide and bury the nerve instead.
Got it. So statistics in surgical techniques are just theory until they are applied to real people. Let's move from the clinical data to the actual lived experiences of the patients in these sources, because they are devastating but ultimately triumphant.
The human cost of these chronic illnesses is just brutal.
Let's talk about Christine's odyssey. Her numbers are jaw-dropping. 4 years of relentless symptoms, 30 different medical professionals, 22 distinct diagnoses,
And 9 spinal taps.
which resulted in cerebral spinal fluid leaks.
Yeah, her brain fluid was literally draining, causing secondary headaches on top of her baseline agony.
And the medical gaslighting she faced was just, it's hard to read. They misdiagnosed her with TB meningitis.
That was wild. They simultaneously told her she tested positive for this lethal infection, but also told her, well, if you actually had it, you'd already be dead.
The psychological toll of that kind of invisible illness is immense. And the hospital records. She was actually labeled a malingerer.
They thought she was faking her symptoms to avoid life responsibilities.
It's tragic. She had to hold onto the walls of her house just to walk because her balance was so compromised, and they thought she was making it up.
It's the dark side of the medical system, unfortunately.
It really is. And then there's Courtney's story, which shifts the focus a bit. Courtney was a woman in her late 20s. She literally felt her youth was stolen. When asked to summarize her existence, her exact words were, "What life?"
That phrase is so heavy. What life?
Yeah. She had reached this grim stage where she just accepted mediocrity. She surrendered to the pain.
Until a late-night Google search changed her trajectory, and she found this surgery.
Right. And the turnaround for both of them is incredible. I mean, contrast their pre-surgery despair with their post-surgery realities.
It's like night and day.
Christine woke up in the recovery room, and her balance was instantly restored. She walked back to her hotel and suddenly realized she wasn't holding the walls anymore.
And Courtney, her friend, said she physically regained the color in her face. She went to NYC and was walking 6 to 7 miles a day.
Effortlessly. A woman who previously had no life, just walking miles through New York City, completely free of pain.
It shows the absolute power of getting the right mechanical fix.
It really does. And I want to speak directly to you listening for a second, because Christine's ultimate takeaway is so important. After everything she survived, she said, "No one will fight for your life like you will."
Relentless self-advocacy.
Exactly. If you know something is wrong, you have to keep pushing until someone listens. So just to recap this deep dive, we've gone from unpinching tight nerves in the neck and forehead to battling this deeply ingrained selection bias in the medical community.
He covered navigating a really complex recovery with ADLs and the eyelid bruising.
And ultimately, we saw how a structural surgery helped real people reclaim lives that were essentially stolen from them by chronic pain.
Which, raises a really important question for us to mull over.
What's that?
Well, if chronic migraines, which have long been thought to be purely neurological or chemical problems, if they can sometimes be cured by a structural mechanical fix,
Right.
what other invisible or chronic conditions in our bodies are we currently just treating with endless medication?
Oh, wow. That's a great point.
Yeah, how many other conditions might actually have a hidden mechanical solution, just waiting for the right specialist to look at it differently?
That is a fascinating thought to leave on. Thank you so much for joining us on this deep dive today. Keep asking questions, keep advocating for yourself, and keep digging deeper. We'll catch you next time.